Assalamu alaikum. In this lecture we are going to discuss about the liver function test and the utility of liver. So the objective of this lecture is the utility of the LFT. It means what is the benefit, why we are doing LFT or liver function test, what are the analytes or what are the components of the hepatic injury, by which method or which test we can say that this is because of the hepatic injury these compounds are coming into the blood, or we can analyze the hepatic function by certain analytes, or you can say by which chemical compounds or things we can say that there is a problem in the hepatic function. And there are different analytes either because of the hepatic injury or hepatic function in the LFT, and their relevance in other disease, because these analytes are not very specific for the liver. However, they signify something wrong in the liver, but we have to know about other diseases also in which these analytes gets raised in the blood. Okay, so what exactly liver do in our body? There are many functions of the liver. For example, liver is involved in the metabolism of carbohydrates and fats and proteins as well. As we know that whenever there is an increased quantity of glucose in the blood, liver used to take it up and convert it into glycogen. And whenever we are in a starved condition, there is a glycogenolysis initially, and then glucose will be exported out from the hepatocytes, and that is taken up by the brain cells and other tissues in the body. Later on, when the glycogen reserves is emptied, gluconeogenesis is started in the liver, and the glucose requirement is being met by these mechanisms. Exactly in the same mechanism, fat metabolism and protein metabolism is also very, very important as far as the liver is concerned. Apart from the metabolism, there are many functions liver do, like for example secretory function. Liver secrete bile acids, salts and pigments. We are going to learn today that bilirubin, and that is a bile pigment, and what is the significance in LFT as far as the bilirubin is concerned. And excretory function, as we have told, the bilirubin is an excretory product of heme. Heme is converted into biliverdin and then to the bilirubin, and bilirubin is conjugated and excreted from the body. And there are certain drugs that is excreted through the bile. There are certain toxins as well that are initially they are detoxified and then excreted from the body. Synthesis. There are certain proteins, like for example albumin, prothrombin. Prothrombin is responsible in coagulation. And there are other coagulation factors also, like for example factor number 7, factor number 9 and factor number 10. Prothrombin is also known as factor number 2. So in total, factor 2, 7, 9 and 10. There are 4 factors that are being synthesized or matured in the liver. And there are storage. Many vitamins are being stored. Carbohydrates, as I have told you earlier, like in the form of glycogen, it's being stored in the liver, and iron also. And there are detoxifications by various conjugation reaction, and in the form of ammonia. Ammonia is detoxified to make urea, and urea being excreted from the kidney. So now we are going to learn what is the benefit of doing LFTs. It is a non-invasive method for screening of liver dysfunction. We screen the patients for any liver problem or any abnormality in the liver, and since it is a non-invasive, and it can be easily done at any peripheral center also, so it is not a very big deal. We can do it. Usually it is being routinely done on all inpatients, with all patients that have been admitted to the hospital, just to make sure that their liver is functioning properly. And the next is to help identify general type of disorder. It doesn't specify exactly what is the problem, but it does analyze that there is some problem in the liver. Then we have to further work up to identify the exact problem in the liver and treat accordingly. And then there are third reason to assess the severity. How severe is the problem, and to tell about the outcome, or we can say prognosis of the situation or the disease. And the last is the when we treat the patient, we want to know whether the treatment is working on that patient or not. We can say the response to the therapy, we want to follow the patient, whether the patient is responding to whatever treatment has been given to you, given to that patient or not. So in that condition, it is a very valuable test. We can simply doing this, by doing this non-invasive test, we can follow up the patient, and we can analyze whether our treatment is working properly or not. Now, based on the classification, like we are going to classify, we are here classified based on the injury. If there is a injury to the hepatic cells, we can classify the patient into mild and moderate, severe or acute or chronic. Nature of what kind of liver injury is this? Is either it is because of the injury to the liver cells or because of the outflow of the bile, obstruction to the outflow of bile. There may be two types of injury. First is there might be some injury in the liver itself or in the cells of the liver. We call it hepatocytes. Or there may be some obstruction to the bile outflow that we call as cholestasis. And the next is the abnormality, or to test the hepatic function. Like I discussed already, there are certain biosynthetic function of the liver. For example, it synthesizes the albumin and certain coagulation factors. So by these two thing, like hepatic injury or hepatic function, we can analyze these two things by just doing a liver function test. So now we had categorized here in this lecture in 4 different types of mode of injury. Like for example, the first is we used to analyze bilirubin. Bilirubin, if it is raised in the blood, it is not solely responsibly coming from the liver, because as we know that bilirubin is a waste product or a degradation product of heme, and heme is a component of hemoglobin. So whenever there is increased intravascular hemolysis or ineffective erythropoiesis, there is increased destruction of the RBC, and more heme is degraded into bilirubin. So in that condition, liver might be absolutely normal, but since the destruction of the RBC or the increased production of the bilirubin is higher than the capacity of the liver to form the bilirubin or conjugate the bilirubin and excrete it. Therefore, in that condition, bilirubin might be raised in the blood. And the other is, but the other 3 response is regarding the liver itself. First is the hepatocytic injury. It means there is some injury to the liver cells, and in that condition, there are 3 enzymes we used to analyze. That is the aspartate transaminase, alanine transaminase, and lactate dehydrogenase. It is abbreviated as AST, ALT, and LDH respectively. In the obstruction to the bile flow, or we can call it cholestasis. In that condition, we used to analyze alkaline phosphatase, gamma glutamyl transferase, or we can also know this enzyme with another name, gamma glutamyl transpeptidase. So we can abbreviate these enzymes as ALP and GGT. So these enzymes can also tell if the concentration or activity of this enzyme is raised in the blood. We can say there is some problem in the obstruction or any obstruction to the outflow of the bile. Now last is the biosynthetic capacity. As we know that there are a lot of things liver is synthesized, like for example albumin and prothrombin and clotting factors. There are 3 clotting factors written here, 7, 9 and 10, but prothrombin is also a clotting factor. We call factor 2. So in total there are 4 factors: factor number 2, factor number 7, factor number 9, and factor number 10. So these 4 clotting factors get matured, or we can say carboxylated, and that needs vitamin K. In that reaction, carboxylation reaction, the vitamin K is a cofactor. So either there is a deficiency of vitamin K that may lead to the deficient production of these clotting factors, or there is some hepatocellular injury that will lead to decreased biosynthetic capacity of the liver. So either in the condition we are going to learn, but if there is a problem in the prothrombin time, then there is some problem in the liver, and the problem might be because of the vitamin K deficiency or because of some other, but there is some problem in the liver. Now the first group, that is the classification of the elective marker of hepatocellular injury. In this, we are going to learn about the two enzymes, that is alanine aminotransferase or aspartate aminotransferase, ALT and AST. So first of all, ALT are more discriminating from liver injury. I mean, it is slightly more specific than the AST, but it is not very specific. I mean, if it is raised in the blood, it doesn't tell there is some injury to liver. There are other things that can also lead to increased concentration of ALT in the blood. But if we consider in comparison to the AST, of course, ALT is slightly more specific for liver. And in ALT is usually present in the cytosol. However, the AST is present in cytosol as well as mitochondria in the hepatocytes. The normal range is 0 to 40 unit per liter in male and 0 to 33 in female. The half-life is 45 hours. What does it mean? It means that we have to analyze the patient sample within this time. Otherwise, there will be degradation of this enzyme over a period of time. Now, we have to know what are other conditions in which there might be some problem in the ALT. So, usually, if, like for example, I have told you that there is a normal range of 0 to 40 or 0 to 33 in female, 0 to 40 in male. But let's suppose there is an increase, 3 times increase. Let's suppose the value comes at 100 or maybe 110. Then we quantify this problem on the basis of how much is the ALT activity is being raised in the blood. If it is raised up to 3 times, then we call it because of the drug side effects. There may be some drug related injury to the liver, or there may be some injury from tissues that is not from the liver. I mean, that is coming from the skeletal muscle, pancreas, lung, or heart. These tissues can also contribute to the ALT in the blood. Therefore, if the ALT is not being much raised, like for example, if it is being raised only up to 100 unit or up to 120 unit per liter in the blood, it might be coming from the liver, but there are more chances that it is coming from the non-hepatic tissues, heart, skeletal muscle, pancreas, and liver. Now, if it is raised 10 times approximately, then it is because of the liver. Of course, it is because of the liver, and sometimes it might be because of some other tissue, but liver is surely involved in that. Like for example, fatty liver, cholestasis, liver trauma, glandular fever, and congestive cardiac failure, ethanoic injury, cirrhosis, chronic hepatitis, metabolic disorder. And if it is raised more than 10 times and up to 100 times, so it will be very much raised, like 4,000 of more, 3,500 unit per liter. So in that much increase in the ALT activity in the blood is because of the viral or toxic acute hepatitis, or maybe paracetamol poisoning or circulatory collapse. These things will lead to so much increase. So for now we learn that ALT is slightly more specific than the AST, but it is not very specific, or it is not absolutely specific, because if some amount of the ALT activity is coming from the heart, skeletal muscle, and pancreas and lungs as well. Therefore, but if it is raised more than 3 times, then usually we consider that some level of injury in the liver is going on. So we have to find out. We used to work up and follow up the patient. Now the next enzyme is the AST, that is aspartate aminotransferase. The normal range is 0 to 20, and it is a marker of hepatocellular domain, also found in cardiac muscles, skeletal muscles, kidney, brain, and RBCs. And we have to take care about the hemolysis, because if we take out the sample and if there is a breakage in the RBCs, or if there is a destruction of RBC in the sample, that we call as in vitro hemolysis, then we have to be careful about, because there is a large increase in the AST level, AST activity in those samples. So it is not the true level of AST in the blood. These are rough guidelines. So the half-life here is only 17 hours as compared to the ALT, that is 45 hours. So we have to analyze the AST in samples as early as possible. There are reasons for increase in AST in the blood. The first of all is the in vitro hemolysis. If there is a hemolysis in the sample, we have to be careful in interpreting the result of AST. And the second is the drug side effects, for example, statins. These statins are basically used to lower the cholesterol level in the blood. Usually all diabetic patients as well as all patients of cardiovascular diseases, we used to prescribe this drug. Sometimes it might come from the skeletal muscle injury or myocardial injury also, and sometimes in the neonates it is usually raised, but it is not very much raised, usually only 1.5 times. Now, what are the other causes? If it is raised more than twice of this normal level and up to 10 times, then it might be coming from the skeletal muscle disease, glandular fever, or maybe fatty liver or hemolytic anemia. And if it is very much raised, then it might be because of the acute viral or toxic hepatitis. It might be because of the myocardial infarction or maybe circulatory collapse. Now the second point is that bilirubin, or we call it raised concentration of bilirubin in the blood, that we call as jaundice, discoloration of the eyes and skin. So icterus, we call it icterus when there is a yellowish discoloration of the conjunctiva, and when there is a yellowish discoloration of the skin, we call it a jaundice. So we know that it is a byproduct of breakdown of the red blood cell. When there is a red blood cell breakdown takes place, the globin portion is reutilized by breaking down of the individual amino acids, and the heme after removal of the iron, the heme portion is converted into bilirubin and then to the bilirubin, and bilirubin is conjugated in the liver and excreted from the body. Usually it is observed when there is increased production of the bilirubin because of the increased hemolysis or decreased excretion of the bilirubin because of the problem or injury to the liver. So there might be two reasons in the yellowish discoloration, what we call as jaundice, or the increased concentration of bilirubin in the blood. Now there are different types of jaundice. So we can differentiate whether it is because of the increased hemolysis. In that condition, it surpasses the capacity of conjugation of the liver, so majority of that bilirubin is unconjugated bilirubin. Okay, and or if there is some injury to the hepatocytes, so in conjugation will be decreased in that condition because of the hepatocellular injury. And sometimes the bilirubin is conjugated, but it is unable to be excreted because of the obstruction to the bile flow. In that condition, conjugated bilirubin will be raised. So there are two types of hyperbilirubinemia. One is the unconjugated. In this condition, either it is because of the increased hemolysis or because of the hepatocellular injury. And the other condition is the conjugated hyperbilirubinemia. In that condition, there is a obstruction to the bile flow. Therefore, the conjugated bilirubin cannot be excreted from the body. Now the third is the markers of cholestasis. Cholestasis means if there is obstruction to the bile flow, we call it cholestasis. There is a stasis of the it means the bile is unable to flow normally. And in this regard, there are two major enzymes we use to analyze to check whether there is any cholestasis or not. One is the alkaline phosphatase, the other is the gamma glutamate transferase. There is one more enzyme what we call as 5' nucleotidase. This also sometimes we analyze, but routinely we do not analyze 5' nucleotidase. Routinely we analyze the alkaline phosphatase and gamma glutamate transferase. The alkaline phosphatase, it is coming from various places. There may be coming from the bone, from the intestine, or from the placenta. Usually in the adolescent age group or in the teenage, or when there is a increased bone growth, in that condition, in that situation, the ALP is mainly coming from the bone source. Or in case of pregnant women, the ALP that is present in the blood is coming from the placental source also, apart from the bone as well as from the liver. There may be some intestinal source also, especially when we used to have a heavy meal. If after that we give the samples for our LFT, then the ALP is coming from the intestinal sources also, apart from the liver and bone. So usually in a normal healthy person who surpassed the age of bone growth, usually it is coming from the liver in a fasting state. So there are many isoenzymes of ALP that can differentiate. We can differentiate which organ is the source of that particular ALP. Either it is bone, intestine, placenta, or liver. So there are different isoenzymes, and based on that we can differentiate. Next is the if we are not sure whether this alkaline phosphatase is coming from the liver or from the other sources, then we can go for the estimation of the gamma glutamyl transferase or 5' nucleotidase. If these two enzymes are also raised, it means the origin is the liver. The normal range is 40 to 125 unit per liter, and if there is a raised in alkaline phosphatase and gamma glutamyl transferase, then most likely the liver is involved and there is a obstruction for the bile flow. Now, gamma glutamyl transferase present in all tissues except muscles, highest level in liver, kidney, pancreas, where most is located in membrane, including the cell membrane. GGT has a role in transport of amino acids and peptide in and out of the cell. The normal range is 10 to 30 unit per liter. GGT is increased in alcoholics despite normal liver function test. If everything is normal in the liver function test, only the GGT is increased, we must inquire whether the patient is alcoholic or not. Usually it is found that in the alcoholics, rest of the LFT is absolutely normal, but the GGT is increased. So it is the earliest sign in the alcoholics that tells us the liver is being, there is some slight injury is started in the liver. Sensitive indicator for the liver disorder, especially for the cholestasis, and it is induced by many drugs as well as toxins. So the last one is the liver dysfunction, what we call biosynthetic functions of the liver is compromised. As we know that liver is a major source of the synthesis of many protein that is present in the serum or blood, and the most important protein is of course the albumin, but there are other proteins also, and I think we have discussed this in other modules also, like in the IBL and other. But there are many alpha globulins and beta globulins that are also being synthesized in the liver. Apart from that, there are also coagulation factors that are being matured in the liver and synthesized as well. In that, prothrombin is very important, and by doing prothrombin time, we can know that prothrombin level is normal or prothrombin maturation is up to mark or not, whether there is a defect in the prothrombin or its quality. Both the things can be analyzed by prothrombin time. And if there is a problem in the prothrombin, or if it is increased, then it means there is a less quantity of prothrombin, or the maturation or carboxylation, what we call carboxylation, post-translational modification is not up to the mark. So serum albumin, it is the major protein. We know that the most abundant protein synthesized by the liver as well as present in the blood, and the normal level is 3.5 to 5 gram per liter. Synthesis depends on the extent of functioning of liver cell mass, and half-life is approximately 20 days. Its level decreased in all chronic liver disease. Now there are other types of protein, what we call as globulins. So the globulins, the normal level is 2.5 to 3.5. There are many types of globulin: alpha globulin, beta globulin, and gamma globulins. Gamma globulins are basically immunoglobulins, and alpha and beta globulins are being synthesized in the liver. However, the gamma globulins are synthesized by the B cells or plasma cells, and there are some kind of gamma globulins that are also raised in liver disease. For example, if there is a autoimmune hepatitis or alcoholic liver disease or some viral hepatitis, in that condition gamma globulins might be also raised. This is very important, albumin to globulin ratio. So if, normally the albumin to globulin ratio is 1.2 to 1.5, but in case of hypoalbuminemia, when there is a low concentration of albumin because of the compromised situation in the liver, some liver cells retain the capacity to synthesize extra globulins to compensate the low albumin level in the blood. Because hypoalbuminemia is not only because of the liver problem, it might be because of the kidney problem also. If there is a increased excretion of protein from the kidney, or we call it proteinuria, massive proteinuria can occur, and in that condition, although the liver is absolutely normal and biosynthetic ability of the liver is also normal, but there is a hypoalbuminemia. In that condition, globulin is synthesized just to compensate the low albumin level in the blood. Now the prothrombin time. Prothrombin is a coagulation factor, or popularly known as factor 2. Synthesized by the liver, a marker of liver function. Half-life is approximately 6 hours, indicate present function. It means if half-life is 6 hours, means if it is a very sensitive indicator for acute injury of the liver, because since the very short half-life, so liver has to synthesize again and again to maintain the level in the blood. Therefore, if there is a decrease in the prothrombin time, it means that there is acute liver injury. However, usually PT or prothrombin time is prolonged or increased when there is a severe loss to the liver, liver lost the capacity to make the prothrombin up to 80%. So in majority of the cases, unless there is a gross injury to the liver, PT is usually normal. But when there is a increase in the prothrombin time, it means that there is a gross injury to the liver, or the liver has lost approximately 80% of its capacity to make this. And in case since vitamin K is required as a cofactor for the carboxylation, or what we call as post-translational modification of these factors, but even if we give the vitamin K, it will not solve the problem of prolonged prothrombin time. Although vitamin K deficiency can cause prolonged prothrombin time, in that condition it can be corrected by vitamin K supplementation. However, whenever there is a problem in the liver, or the prothrombin time prolongation is due to the liver diseases, the vitamin K supplementation might not have any role in that. So this is all about the liver function test. Thank you very much.